Okay, I think people are still joining, but I think we'll go ahead and start. So thank you all for attending the second Chronicle of Wound Scene Investigation webinar series presented to you by the Wound Healing Society Education Committee. Please note, if you have any questions, please utilize the Q&A feature in the box, and we'll address any questions after the talks. Hopefully we'll give ample time to address every question. As a reminder, this is being recorded. So welcome everybody. We have our panel here of 4 of us, and I'll start with my introduction, then everybody will then go in turn. So I'm Romana Aslam, and I'm the chair of the Education Committee. I'm faculty at Yale and practice wound care, and my interest is in outcome-based wound practices and wound education. I will now pass it on to Lisa Gould, our speaker for tonight. Go ahead, Lisa.
Hi, I'm Lisa Gould. I'm a plastic surgeon. I consider myself a wound surgeon and have for quite some time. I'm a past president of the Wound Healing Society, long-term member of the Education Committee, and I am currently working at South Shore Health in Weymouth, Massachusetts, where we have both an inpatient wound team and I work in the wound center. And I know that there are several people from the wound center on the call tonight. And Lee?
Good evening. My name is Lee Ruotsi. I am the medical director for the Center for Wound Healing and Hyperbaric Medicine for the Saratoga Hospital System in beautiful Saratoga Springs, New York. I have been practicing wound care now on the outpatient side as well as inpatient for about the last 15 years. And I sit on the board of directors of the National Pressure Injury Advisory Panel. And certainly enjoy the practice of wound care and the opportunity to teach as well.
Harvey?
I'm Harvey Himel. I'm a wound doctor as well. I'm a plastic and general surgeon who previously did burn care for 10 years. I've been a member of the Wound Society for 30 years now and on the Education Committee for about 12 years.
Thank you, everyone. Lisa, you're going to present the flip book, and I'll take it from here.
Okay. So for those of you who are Wound Healing Society members, you may have already explored the website and gone to Wound Healing U. And if you do that and click on the Chronicles of Wound Scene Investigation, that will take you directly to the flip book and you have full access. For those of you who are not Wound Healing Society members, you can go to Wound Healing U and click on the flip book and you'll get just a little snippet enough to make you want to join the Wound Healing Society. And then you'll have full access to the Chronicles of Wound Scene Investigation. This is a 10-year compendium of the wound scene investigation presentations from the SAWC, and we've tried to stay true to how they were originally presented with a little bit of augmentation where it seemed like it would be hard to understand if you only saw the slide. But I think it's a great collection of cases and science behind it. Let's see. There we go. And so we're going to start tonight with one section from 2012. And remember, this is what we knew in 2012 when it was presented as Wound Scene Investigation, which is why it's called Chronicles of Wound Scene Investigation, going from bedside to bench. And tonight's topic is osteomyelitis. So when you look at wounds, often the first thing you think, especially with pressure ulcers, is, does this patient have osteomyelitis? And so we look at these 4 different presentation types and think, you know, if I put my finger in there or a probe, would I know whether this patient has osteomyelitis? And the answer is that all of them did, but you really can't tell just by looking. And we're going to explore what that means tonight. So what is osteomyelitis? It's an infection of the bone and the bone marrow, and it can be either acute or chronic. It's a little bit better defined in the long bone. But what we're going to really focus on tonight are the osteomyelitic lesions that are associated with pressure ulcers. We'll talk a little bit about the others, but mostly we're going to focus on pressure ulcers. Osteomyelitis can occur hematogenously through the blood, and that's most common in children. Contiguous spread from the wound or direct inoculation, say, for example, from trauma. If an open tib-fib fracture that gets dirt in it will be a direct inoculation. If the patient has healthy bone, that's really resistant to infection. But when the bone has been injured or devitalized by trauma, inflammation, or vascular insufficiency, it's much more susceptible. So in pressure ulcers, there's contiguous spread to the bone that's been damaged by decreased vascularity that's due to pressure. And so that's why pressure ulcers can get osteomyelitis. In the foot, it's a little bit different. It's also a contiguous spread. And then the diagnosis is a little bit more clear cut. A bone biopsy for culture is fairly easily accomplished. The positive probe to the bone has been a test that's been used for many years and has a positive predictive value of 89%. Now, when this was first described, it was described as a very characteristic test using a metal probe and probing to the bone with this characteristic clunk when the metal hits the bone. Whereas now I think people just say, well, I know the bone is exposed, therefore they have osteomyelitis. But that would be augmented by imaging studies. So the foot x-ray has a sensitivity of 60%, but a specificity of 50%. So it's kind of like tossing a coin, but a triple phase bone scan has a sensitivity of 100%. Dual isotope scans, where it's labeling the white cells, it has high sensitivity and specificity. And then the MRI is probably what we're using most these days, with a sensitivity of 70%, specificity of 100%. And that's really good for deep abscesses, septic joints, osteomyelitis, and tendon ruptures. So you see more than just the osteomyelitis. So here's somebody doing a bone biopsy, which can be done in the clinic as long as the wound has been cleaned first. And then a positive probe to the bone. Here, again, they're not using the metal probe, which is how it was originally described. Osteomyelitis can be seen in the foot on plain films. And so on the left, you see just the washout of the bone, and it's clearly osteomyelitis in that second metatarsal, and then in the heel, that's an MRI there where it really lights up and shows a cyst as well. And so you get exquisite definition with an MRI in the foot when they're done well. Pelvic osteo, on the other hand, is a little bit fuzzier. One of the documented ways to diagnose osteo in the pelvis is fever and the presence of a wound. That seems a little too diffuse. I get called many times to see patients with fever and a wound, and they have a urinary tract infection, not pelvic osteomyelitis. The combination of elevated white cell count, elevated SED rate, and a pelvic x-ray that suggests osteo has high sensitivity and specificity. Bone scans were often used in the past, not so much anymore, although Dr. Himel will say that they are used at his institution, so it can be institution specific. CT scans are often used. I'm often called after the CT scan has already been done. MRIs, not as much for pelvic osteo, but both the CT scans and the MRIs are done. They can be difficult with having hardware in and getting a lot of artifact. And then the bone biopsy is still the gold standard. So what do these imaging studies tell us? Well, the pelvic X-ray, if you can get one on somebody that has a pressure ulcer in the pelvis, can show periosteal reaction where it shows up brighter white and a little bit fuzzy where the periosteum is. Heterotopic new bone will show up, and cortical destruction. In chronic osteomyelitis, the bone will be sclerotic and also may have periosteal reaction. The problem is that the findings persist even after successful treatment. And so the sensitivity is 18%, but the specificity is 100%. But again, it can be very difficult to get patients positioned correctly and to actually see what you're trying to look for in the pelvis. The bone scan, which is the technetium bone scan, is looking for areas of increased bone turnover, has a sensitivity of 64% and a specificity of 57%, whereas the indium scan, where the white cells are actually going to go to the active infection, has very high sensitivity and can have high specificity, but knowing that the bone marrow activity may lead to an inaccurate interpretation. And if somebody already has a wound, the white cells will go there too. CT scans are very good for the extent of deep soft tissue injury. So if there's something in addition to osteomyelitis, or you want to get the extent of a cellulitis that's accompanying the wound, it's excellent for that. But the sensitivity for osteomyelitis is only 11% with a specificity of 90%. And then the MRI, where we're looking at the T1 and T2 weighted images and comparing that, is better than the CT scan for bony changes. As you can see here, there's pretty good definition of those femoral heads with a sensitivity of 98%, specificity of 89%. MRIs are more expensive and sometimes hard to get, especially again with positioning and the length of time that the patient has to be in the scanner in order to get good images. So then we would like to know, can I just do a wound culture and will that guide my therapy? But the organisms in the soft tissue have been shown to not correlate with bone. And you can see from this graph or chart that organisms that are isolated in the bone that were in the wound culture are about 50-50, whether they're isolated in the bone or not. So you can't go by just the soft tissue. And then if you are able to get a bone biopsy, it can have some problems as well. There's a high false negative rate, and that's probably a sampling error. Intraoperatively, the surgeon can evaluate the bone characteristics, looking for pinpoint bleeding, whether the cortex is intact and what's the consistency. But the sacral bone is soft, so it's really hard to judge the consistency anyway. Some people do pre and post debridement biopsies, because post-debridement biopsy may not have anything left in it if it was a very extensive debridement, but that may tell you that you cleared the infection anyway. But in the operating room, you do have access to a large amount of bone, and I certainly take advantage of that and send as much as I possibly can. For a while, I actually was using the Jamshidi needle as a way to do a biopsy. This was popularized by a plastic surgeon from Chicago, and you can do it at the bedside, but unfortunately there's a low yield. Again, a sampling error, and it can be painful for patients if they have sensation. It's the needle that's used for bone marrow biopsies. And so you don't always get a lot. It can be difficult. And then histopathology from the bone biopsy. So you can send for culture and you also send for histopathology. And histopathology can give you a definitive diagnosis if your pathologist will be forthcoming. I learned when I was working at the Tampa VA that the pathologists don't actually have a gradation or any sort of an algorithm to give you a diagnosis of osteomyelitis. But when it's positive, or when you do it with histopathology, you can get a 73% sensitivity, 96% specificity. In the cultures, there are about 5 top organisms that are involved in pressure ulcer osteomyelitis, with Staph aureus leading the pack, but also Enterococcus, Pseudomonas, diphtheroids, and coag-negative staph. If coag-negative staph or diphtheroids, which are sometimes thought of as being skin organisms and contaminants, but if they're in the bone, that's a pathogen. Why do we treat it? Well, it can reduce postoperative complications. You may, if it's undertreated, the patient may come back later with a deep abscess or a sinus tract, even if they had a flap coverage or had a wound closure. Years later, it can open up and you'll go directly to the bone. Treating the osteomyelitis can reduce the wound recurrence. And remember, this presentation was done in 2012, so the numbers here look really, really old. The 1996 incremental cost per pressure ulcer, if it was just a pressure ulcer treatment, was $2,731, but if it was associated with osteomyelitis, it costs $59,000. Historically, we have given people 6 weeks of antibiotics. And if there wasn't a culture, those antibiotics were empiric based on the usual suspects, or better yet, culture-guided antibiotics for 6 weeks. But the question is, what is that actually based on, and why do we use 6 weeks? It was an experiment in 1971 in an experimental osteomyelitis in dogs, and it was done by Nord and published in the Journal of Infectious Disease. So we don't have a lot to base our treatment on, and a lot of people don't know where that actually came from. Another method of treatment is surgical excision of the bone and flap coverage with and without antibiotic therapy. And of course, that's been popularized by the plastic surgeons who like to cover things with flaps. How do we treat surgically? And this has been my method for quite some time. And first and foremost is debridement. And painting the ulcer with methylene blue, that guides us to where the actual wound is, because once you start cutting, everything turns red. Excise the wound and then irrigate it, and then obtain the bone for pathology and microbiology. And then if it's a suitable patient, cover with a muscle or a fasciocutaneous flap. Initially, it was thought that only muscle should be used when there's osteomyelitis, but later the plastic surgeons in pretty good studies showed it just needs vascularized tissue, and a fasciocutaneous flap is well vascularized and you don't need muscle, and it's easier to re-elevate if that's needed later. And then the antibiotic treatment should be guided for the bone that remains in the patient, meaning you're doing your biopsy on what's staying with the patient, not what was taken out. If medical treatment is the only option, one of the questions is whether a patient, or is an additional option, should the patient get pre-flap IV antibiotics? And again, that can be empiric. It can be based on culture from a Jamshidi needle, if the patient didn't go to the operating room at all, or if it was a staged procedure, it can be from the operative debridement. But there's no data for how long to treat prior to surgery. One postoperative algorithm, so this is post-op, and it's from the group that was in Chicago with Han et al., is to, they trusted their pathologist very well. They had a great relationship with their pathologist. So if the culture was negative and the pathology was negative, they would treat with antibiotics, empiric antibiotics, for 5 to 7 days. If the culture was negative, but the pathology was positive, you still have to treat with empiric antibiotics because you don't have a culture to treat, but they would treat for 2 weeks because they felt the pathology trumped a negative culture. And then if both were positive, they would treat for 6 weeks. Again, that doesn't have any data to show that they were actually curing the osteo. And in fact, we don't have any way to know when osteo is cured. And I think it would be a great study. So that was the presentation in 2012. Now we're going to look at what have we learned since. Have we learned anything? That's a good question. So I'm going to show you a case, my own patient. He's a 59-year-old male who has MS, and he presented to the hospital with a sacral abscess. Now, it was probably a pressure-induced abscess, but and I didn't see him initially, but I was told it was an abscess. The CT scan showed some degenerative changes in the bone, but no suspicious osteosclerotic or osteolytic lesion. Therefore, based on CT scan, no osteomyelitis. and incision and drainage was done by general surgery, and the culture showed normal enteric flora. Well, I would maintain that it's not normal to have enteric flora in an abscess of the skin. So I found that a bit puzzling. And then when I was called to see the patient, he did have wide undermining. What you're seeing in the photo are a couple of Penrose drains. So one open wound and then connected by Penrose drains, and that's where the undermining is. And when I put my finger in the wound, there was a very sharp bone that nearly cut my glove. And I felt that the patient probably needed to go to the operating room to have a little bit more exploration. But we should always go back and say, well, what would the literature say I should do? Do we need to take patients to the operating room? Do we need to treat them with antibiotics? And so that's what we've done to update for this particular presentation in terms of the Chronicles of Wound Scene Investigation. This is our new presentation. So from 2015 to present, it's actually in the literature that this is an understudied entity in the field of bone infection. We're talking about pelvic osteomyelitis being understudied. And there are mixed views. One view is that sacral osteomyelitis may be overdiagnosed and overtreated. And then the other camp says pelvic osteomyelitis is a neglected disease. Let's look at sacral osteomyelitis. So it may be two different things. We may be mixing apples with oranges, looking at sacral versus pelvic osteomyelitis. So the literature, and this was in the Journal of Bone and Joint Surgery Reviews in 2020, the literature says that there's a difference between surface colonization and infection. And a positive probe to the bone in the sacrum is not equal to osteomyelitis. But inflammation may be the distinguishing factor. So positive probe to the bone and then tissue, bone tissue that shows inflammation would suggest osteomyelitis. The most common organisms in sacral osteomyelitis are the staph organisms, MSSA and MRSA, strap, which wasn't listed in 2012, Pseudomonas, and Enterobacter. There's no evidence, according to this review, to support prolonged preoperative antibiotic therapy. And then most sacral infections, according to Marriott and Rubai, are focal. Wong et al. And Larson, two different papers, said that there's no indication for long-term antibiotics if surgical coverage is not planned. Pelvic osteomyelitis may be different, but in these two different articles, they mixed sacral, proximal femur, and ischial osteomyelitis and found that the wounds, as we know, the wound swabs do not correlate with deep bone samples. Elevated CRP gives you a poor prognosis. Antibiotic duration is not correlated with treatment failure, and it requires a multidisciplinary team that addresses all of the factors, including the risk factors for pressure ulcers. The diagnostic algorithm, which was proposed by Brunel et al. In 2016, looked at a prospective study of young spinal cord injury patients. Again, it's mixed sacral and ischial. They really found that MRI was not routinely useful for diagnosis, and they used a similar protocol to what I do, although they irrigated with betadine, washed with saline, and then debrided the bone, and then they got their biopsies with a clean rongeur, which is the tool used to get the biopsy. And their diagnosis of osteo is based on positive histology, and then they sent multiple samples for bone culture. So if at least one was positive with a non-commensal bacteria, or 3 were positive with commensal bacteria like those diphtheroids, then they that had a 79.5% rate of osteomyelitis. Now they say their study of healing is in progress, and we haven't seen that. So this is that patient after I took him to the operating room, and you can see that there is exposed bone and a little bone shard, and that was sent for pathology and microbiology. The pathologist told me that there were fragments of bone with acute inflammation, granulation tissue, and remodeling changes and fragments of cartilage, but didn't say anything about osteomyelitis. And then the bone culture was positive for Pseudomonas. But wounds can be deceiving. This is a wound that doesn't have any obviously exposed bone in a quadriplegic who had several ulcers that were open for 2 years. And his CT scan 7 months prior to seeing this wound was reported to be normal. He had a normal white count, but he'd had several previous infections, primarily urinary tract infections. And then he got a CT scan for another reason, and it demonstrates that he basically created an autogirdle stone. The hip socket on the right is completely destroyed, and he has heterotopic bone as well. And so that was kind of a fooler, because you wouldn't have known that from looking at the wound on the outside. So where does the literature agree? It agrees that pelvic imaging has limited usefulness. If getting it, the MRI is better than the CT, which may be better than scans, but the scans may be helpful when the MRI is contraindicated, and it may be location dependent. There's no consensus regarding the histopathologic diagnosis of osteomyelitis, and there's no evidence regarding the duration of antibiotics, and no literature to support long-term suppressive antibiotics, which many of my infectious disease doctors have recommended. There's no literature regarding healing without flap reconstruction, and we all agree that a multidisciplinary team is important. So with that, I am going to turn this over to Lee. Oh, here's our literature, sorry. The two camps, the minimalists and the aggressive but antibiotic duration unknown. So we will let them duke it out. It'd be fun to have a debate between these two camps. All right. So now I'm going to let Dr. Ruotsi Lee give us some pearls of wisdom that will summarize what we have learned.
Thank you, Lisa. And maybe for this topic, we should call them fragments of wisdom instead of pearls, given the bone. Pleased to be here once again with Drs. Aslam, Gould, and Himmel. And my job is to sort of put a ribbon around this package and sort of hit the high points. So I divided this up into 3 sections: what we know, what we don't know, and what seems logical and reasonable. So we know that sacral and deeper pelvic osteo are common problems associated with advanced stage pressure injuries or ulcers, usually stage 4, that have exposed bone, tendon, and other deep structures. This problem is going to increase in prevalence with the aging and sicker population in hospitals, skilled nursing facilities, and LTACs. And we know that antibiotic treatment in the absence of surgical intervention, not necessarily flap closure, but debridement or flap, is not logical. So flap coverage is not always essential or advised based on the setting. Next slide, please. What we don't know. We don't know what the optimal duration of antibiotic treatment is for osteomyelitis, following, of course, appropriate bone and soft tissue cultures. And I just want to reiterate an important point that Lisa made, and that the only gold standard is the biopsy of affected bone. So this also is an opportunity just to remind all of us that our diagnostic imaging colleagues, as well as our pathology colleagues, are sort of in a vacuum if we don't provide some reasonable history for them. The pathologists are looking through a microscope. The diagnostic imaging folks are looking at their screens. And, you know, one of my dear friends is a radiologist, and he and I had this conversation often. He said, you know, if you order a CT of the pelvis, you know, I'm going to look at it and I'm going to do my best to tell you that it's normal or there's something wrong with it. But if you tell me that you suspect a right ovarian pathology, or in a chest x-ray that you suspect something, you're going to help me a lot in giving you a diagnosis. So the same thing with the histopathologist. We need to tell them that we're suspicious of osteomyelitis or we're suspicious of a malignancy. Otherwise, they're just in a vacuum. So we also don't know what is the optimal route of delivery for the antibiotics. Is it oral or is it intravenous? There are some studies now, especially in the diabetic foot literature, suggesting that oral antibiotic regimens have better bone penetration than some of the IV regimens. And what is the optimal diagnostic imaging modality? Well, Lisa went through those very, very nicely: MRI, CT, bone scan, indium scan. But another point there is that sometimes that there's a little bit of variation depending on the comfort level of the folks in your institution and what it is that they're used to using. Next slide. So then finally, what seems to be accepted and logical? Well, first of all, not just a multidisciplinary approach, but actually an interdisciplinary approach where people actually talk and work together to figure out this problem. Nutrition is extraordinarily important in the treatment, recovery, and rehabilitation of folks with pelvic and sacral osteomyelitis. And the concept of prehabilitation is important. In other words, getting that nutrition evaluation early on and sort of boosting people in the pre-treatment, pre-operative phase to make sure that their nutritional status is adequate. And I'll also throw out the sad commentary that the prealbumin molecule that we all used to rely on so faithfully for determination of nutritional status is not any longer recognized as reliable, especially in the patient that has some sort of inflammatory problem for which osteomyelitis certainly qualifies. Nursing services, inpatient and rehab and skilled nursing facility, we need to be sure that we have appropriate pressure redistribution surfaces for the beds and the chairs, turning and repositioning based on individual patient factors. Social services, we need to understand what the patient support network is, not only within the facility, but also once they are discharged and have gone home. Next slide, please. So we need our general medicine and infectious disease partners. You know, the old saying that we've all heard: we can't just take care of the hole in the patient, we have to take care of the whole patient. So management of diabetes and autoimmune disorders and COPD and congestive heart failure, all sorts of other things, in addition to the infectious disease component of the problem. Surgical intervention really depends on local practice patterns. I think in most areas, the treatment of advanced pressure ulcers or pressure injuries is in the wheelhouse of the plastic surgeon, but in other areas, it falls under general surgery and or orthopedic surgery. So, you know, your particular environment is what it is. Preoperative diagnostic imaging, again, Lisa went through this very thoroughly: plain films, MRI, CT, three-phase bone scan, tagged white blood cell studies. And again, depending on the comfort level of the folks reading those studies. Next slide. Soft tissue and bony debridement of all devitalized tissue is critical. Flap coverage, depending on the case. Not always the right thing to do, but again, to reiterate that long-term antibiotic treatment in the absence of surgical intervention, at least debridement, does not make any sense. Antibiotic treatment should be based on bone and soft tissue cultures, and again, to reiterate the importance of meticulous post-op nursing care. Next slide. Okay, and that's the end for me, but I had one little note left that I wanted to make regarding the determination, the histopathologic determination of the culturing of osteomyelitis, remembering that swab cultures of the exposed bone are essentially useless. They tend to yield contaminating bacteria rather than actual pathologic bacteria. So, Dr. Himel, over to you.
Thank you. With all this information, not only do you want to assemble a team, but you need to understand the strengths and weaknesses of your team members. And when it comes to addressing this, it starts with a diagnosis, of course. And in that case, you want to poll your imaging colleagues for the most accurate method. And then review the scan with a radiologist, including the assessment of regional perfusion with the vascular surgeons. So that if all you have available is plain films, you're looking for a violation of the cortex. And that takes about 6 weeks of resorption time to really assess a brand new situation. On the other hand, the CAT scan is far more sensitive. It's a three-dimensional image rather than a flat planar view. And there are institutions where they can get a good deal of information from a CAT scan with and without contrast. Nearby here in Manhattan, where I practice downtown at NYU, they rely primarily on the CAT scan with contrast. Over at Cornell, where I used to work, the Hospital for Special Surgery has some of the finest MRI radiologists in the world, and they're able to assess using a differentiation between T1, T2 images, where T1 is the bone marrow, primarily, that has a certain signal when it's healthy. The T2 will show change to T2 when the bone marrow has been destroyed and replaced by fibrous tissue that has a higher water content. At Mount Sinai, where I practice, we have a far more sensitive and specific information from start with a 3-phase bone scan using technetium MDP. And it will start with a perfusion or flow study. And you'll see a flare in the area where there's an acute inflammation. And during what's called the equilibrium phase, there'll be a pooling of the blood there. And finally, the third phase is where there's what we would call washout. And the delayed image will stay active with a lot of the technetium radioactivity in a patient who has an active osteomyelitis. In cases where it's suggested but not convincing, the next step is to obtain a blood sample from the patient and label their white cells with indium, which seems to be selectively taken up by granulocytes, so that on the next day, if you get an image with a good deal of radioactivity, that would suggest that there's an acute infiltration by granulocytes that are the first responders to infection, showing acute osteomyelitis. And they'll try to localize that with a single photon emission CT scan, or SPECT. In the case of chronic osteo that's going to take a long time to resolve, the latest thing that people are using is gallium-68. Gallium mimics iron, so there's uptake by bacteria that are trafficking into the wound, or residing in the wound, I should say, as well as the leukocytes will bind to the gallium and carry it into the wound. And if you're trying to determine whether or not a chronic or long-standing acute osteo is resolving, you can assess the gallium content there using PET scan, since the gallium-68 emits positrons. With that diagnosis secured, the treatment is based on confirmation of the organism. And whether your surgeons or your interventional radiologists are willing to get you a specimen is something that also varies by institution, as well as the location of the bone and whether there is access to that for these different specialists. And as discussed earlier, you want to review this with the pathologist as well as infectious disease. And all the while, you're supporting the patient, recognizing that they're going to be nutritionally depleted by this inflammation that puts them in a catabolic state. And in addition, you want to be able to mitigate trauma to the wound with this seating surface and the bed surface. Since this is a chronic wound, you're going to need serial exams to monitor the inflammatory markers until it's resolved. And I'll be happy to take any questions at this time. I think Greg's question should go to Lisa.
Now, Lisa, do you see the question?
I did, but maybe you can read it for people because I had to wade through it while I was trying to listen to Harvey.
Yes, I will. And this question is actually from one of our longstanding wound scene investigation partners, Dr. Gregory Schultz from the University of Florida. And he says, or asks, great presentation, Lisa. What is the official position on requiring clinical microbiology labs to use ultrasonic energy treatment for tissue biopsies, swab cultures, or bone scrapes to disperse bacteria in mature biofilms into single bacteria or microcolonies to be able to detect the presence of bacterial biofilms on bone tissue or soft tissue? The problem is that not detecting bacteria in mature biofilms is because the wound samples are not subjected to several cycles of ultrasonic energy treatment. To standard clinical microbiology lab protocols only detect planktonic bacteria. We analyzed several bone and soft tissue samples from suspected osteomyelitis and found no colony forming units unless the samples were ultrasonically dispersed before culturing. Then all were culture positive. So it sounds like what Greg is asking is, what is the utility of ultrasonic treatment to disperse biofilm bacteria into a planktonic form before culturing? Greg, I hope I didn't mess that up.
Right. I know what he's asking. And I mean, we're lucky that we get the labs to even do anaerobic cultures, much less doing ultrasonic dispersion when they get the specimen. What I don't, there's no requirement, but what I don't know is when I send bone to the lab, because I send it fresh for the culture, what do they do with it? You know, they must grind it up, but I don't think they're doing ultrasound. And it would be something to actually ask the lab about. And I mean, certainly many of the bony infections are based on biofilm. But I think I'm probably also having, you know, my cultures come back positive. So with my protocol where I do my debridement first, and then I irrigate, and then I do the bone biopsy, sometimes it takes long for the culture to be positive. But when it is positive, I know that that's a real answer. But to your point, we may be missing things. Because there may be biofilm bacteria, non-planktonic bacteria in there. So that'd be something to explore with the labs that are doing the cultures.
I think in both cases, you're using some type of kinetic energy to disrupt the surface that has the planktonic cover layer. And then you're sampling something more representative of what may be going on in the deeper nooks and crannies of the marrow.
Mm-hmm.
All right, next question. We are tackling a diabetic foot ulcer osteomyelitis approach on our amputation prevention team. And maybe this should be a separate wound scene investigation. We keep running into discordance between path and micro, which we find in the literature is more often than not regarding bone biopsy for foot wounds. The cultures are usually positive in our case, not negative, and the path is negative. The IWGDF guidelines say to treat as osteo for 6 weeks if either are positive. So is what you reviewed today, the 2 weeks if either positive, more for pelvic osteomyelitis? So for me, I think there is a difference in the literature between pelvic and sacral osteomyelitis and especially diabetic foot osteomyelitis. But Lisa, what do you think?
Yeah, so when you look at the diabetic foot, we're almost treating it like cancer, right? So we can have imaging studies that tell us kind of the extent of the osteomyelitis. The debridement will go back to visibly healthy bone. And then many times people are going for what they call the negative margin. So, you know, they get as much out as they can, and then they do another biopsy, and you want that to be negative for both path and micro to say that you got it clean. I think the antibiotics at that point are treating the microscopic disease. Just like you are in cancer when you're using chemotherapy, you go in with your knife, you take out the bulk, and then you are treating what's left with the chemotherapy. That's kind of how I view it. The 2 weeks that I mentioned, that was based on a pelvic protocol. That was not based on foot osteo. So I think, again, we don't know the actual needed duration because you're not going back in to see if you have anything positive after you've treated it. I've recently had the luxury of going back in on a patient who had a widely exposed sacral bone, and not a pressure ulcer, but it was a radiated wound. And it's very interesting because we had 2 organisms initially, Proteus and Enterococcus, and it's not minimal. She definitely didn't fall into the minimalist approach. So wide debridement, got those 2 positive cultures, treated her with antibiotics for 6 weeks, had to go back in order to do flaps. And then that bone culture was still positive for Proteus. And then went back in again just recently, and that culture is positive for the Enterococcus. So the 2 original organisms were Proteus and Enterococcus, and now she's had one of each. It's better. The inflammatory markers are better, but it's a really deep-seated osteomyelitis. So you can't say that that's not going to be, that can't be treated minimally. That's not just a surface bacteria.
It might be time for HBO when it's so refractory. Yep,
already signed up.
I'll also throw in, you know, if you're a non-surgical provider referring a patient with osteomyelitis to a surgeon, remember, and you know, some people may be offended by this suggestion, but it never hurts to remind, especially in the diabetic foot osteo, remind them to please send culture for, or send a bone sample for culture as well as histopathology, because, you know, sometimes in the heat of the day, the surgery is done and the bone is resected, but nothing ever gets sent to the lab. So it doesn't hurt to remind your surgeons to send those samples.
Mm-hmm.
There are questions in the chat.
Mm-hmm.
There are, yes. So there is a suggestion, comment from a physical medicine and rehab physician, well-known and respected to all of us. I would also like to mention the importance of PMR on the team. These patients often are paraplegic, quadriplegic, or hemiplegic. They develop contractures, which put abnormal pressures on the sacral and pelvic areas, often transfer, and equipment are poorly done, and or fitting causing trauma. Trauma is not just about seating and beds. Thank you for that. Nicely said.
Yes.
There's another question about how successful treatment of a diabetic foot ulcer is with just IV antibiotics or in conjunction with hyperbaric. It's the same as pelvic osteo there. It's a combination treatment with surgical eradication and then treating with the antibiotics. And the indication for hyperbaric oxygen therapy is chronic refractory osteomyelitis. And that means that they've already been treated and you still have osteomyelitis and you're actually actively treating with antibiotics while they're getting the hyperbaric. So that's a very specific diagnosis.
And a small addition to that is the other addition or the other indication for hyperbarics with osteomyelitis is in the Wagner 3 diabetic foot ulcer with active osteo or deep space infection. And again, hyperbarics as adjunctive therapy to debridement and antibiotics and offloading and proper wound care and so on and so forth. But the Wagner 3 diabetic foot with underlying osteo is another indication.
And it's known that the hyperbaric oxygen will reduce edema and will foster angiogenesis, which can be vital in the diabetic foot. In addition, the oxygen itself that penetrates more deeply when it's carried by the hyperoxygenated plasma will serve as an antibacterial agent in and of itself. A lot of these bacterial species are sensitive to high concentrations of oxygen since they don't have lungs.
Right.
And with that said, there are patients who cannot be put in a chamber or will not be approved by the third-party payers. In some of those cases, if you can debride all the necrotic bone and have some healing soft tissue around the area, if that stalls, sometimes it helps to use topical oxygen because it is able to act as an antiseptic during those treatments by bathing the wound with a cloud of oxygen.
Yes. So Harvey, to that point, I think there over the last probably 4 or 5 years, there's been a renewed interest in topical high pressure oxygen in the treatment of these wounds. And I think we just all need to understand the difference between topical high pressure oxygen and actual hyperbaric oxygen, systemic hyperbaric oxygen, right?
Right.
I will just add that to support Harvey's and yours, that it does act as an antibiotic, hyperbaric oxygen. And even if topical oxygen can penetrate and increase the tension, as you all know, Dr. Hunt's article way back when was titled Oxygen as an Antibiotic. And it does explain how oxygen will, turn into radical oxygen species and actually have the neutrophils do more killing. The rate of action of neutrophils to kill bacteria increases with increased tensions of oxygen. So yes, that is very true.
So Heather is reposing the question about the diabetic foot ulcer, which we weren't intending to talk about diabetic foot, but I know it's a difficult problem. If you can't visualize the bone in the wound bed and the MRI is positive for osteo and the inflammatory markers are high, would you debride down to bone even though it's not visible in order to eradicate the osteomyelitis? I think that, there's a couple of approaches you can do, right? So it depends on your surgeon and whether they want to go in and expose bone that's not already exposed, or treat longer with antibiotics that have good uptake in the bone, and cross your fingers. I still, some people do get better. We don't have a lot of data on this. So a long duration of antibiotics or treat and watch, really carefully watch and then start back up again if you need to, when you don't have other options. I think that that's certainly done. But you have to be aware that it may not be fully eradicated and it may show up later. And then the diabetic foot ulcers, they show up later anyway.
They do. And I think sort of the summation is that the optimal treatment for diabetic foot osteo is a combination of surgery and medical treatment, antibiotics. But we also have to remember that there is always a group of patients that are unable or perhaps unwilling to go to undergo surgery for any reason. And so in those cases, you do the best you can, and you offer them the best options that their particular case will accept.
I think we don't want to forget that off waiting is a sine qua non for treating.
Mhm.
Yeah.
Has
So-
to be completely taken out of the patient's discretion. It has to be imposed upon them in order to be sure that that is not a component in the prolonged illness.
I think that everyone agrees, Harvey, that the single most important intervention for diabetic foot ulceration is, it's as they say, it's more important what we take off the wound than what we put on it, right? It's got to be entirely offloaded. And
Yes.
I always say about hyperbaric oxygen therapy or about the diabetic foot ulcer, it's a package of care that's going to help. It's not one thing. It's not wound care. It's not debridement. It's not antibiotics. It's not hyperbarics. It's 5 or 6 things put together with a patient that accepts their role in the treatment.
I think one of the things that makes it more complex than than the soft tissue infections is the fact that bone doesn't melt. It's a rock. It has to be chipped out in order to remove the hiding place of the bacteria in that necrotic tissue.
Right.
They have to be evicted.
There is one more comment. I think that's the last one. If you want to address that, I think it is what Harvey, you're actually saying. So do you see that, Lee?
Is this in the chat or in the question?
It's in the
Q&A.
chat, actually. It's
In the chat?
this is-
This is the last one that starts with, thank you very much.
yes.
Okay, so thank you very much. Wonderful talk. Love the fact that you acknowledge institutional bias. In our institution, it is very hard to get any class of surgical specialists to sign on to a case and help with interventions. They are sightseeing recent literature that shows very poor surgical outcomes. To clarify, they are referring to reconstruction.
Yep. As somebody said, I'm rare as hen's teeth. So.
Yeah.
No,
Well, and I think in most institutions, Lisa, and I struggle with this, most folks have trouble finding a surgical specialist, especially a plastic surgeon, that is willing to sign on and become invested in sacral and pelvic osteomyelitis. It's tough. You and Harvey are rare as hen's teeth, no question.
Okay, we have 1 minute left, so I think that was the last question. We will go ahead and wrap up.
I think
So thank you to our wonderful speaker. It was a delight, and the other speakers, this was a treat. Thank you to you all. And thank you to the attendees to attend the second webinar in the Chronicles of Wound Scene Investigation series. As a reminder, the recording is available to the members of Wound Healing Society in your member-only account. It will be available in the next few weeks. Please be sure to mark your calendars and attend the next webinar on Tuesday, March 8th at 6 p.m. Eastern Standard Time. And the topic is chronic wound environment, which will be presented by Greg Schultz. So thank you all, and stay well and stay safe.
Good night.
Good night.
Thanks, everybody. It was fun.